Hello, my name is Jess Dunkley and I'm a trainee nurse practitioner. The title of my poster is Interstitial Ectopic Pregnancy and the Role of Ultrasound. Ectopic pregnancy is a type of abnormal pregnancy in which implantation of the blastocyst occurs outside the endometrium cavity. Ectopic pregnancy is amongst the leading causes of mortality amongst pregnant women. The majority of ectopic pregnancies are located within the fallopian tube. However, there are other implantation sites. This includes a cervix, caesarean section scar, interstitial portion of the fallopian tube, corneal, ovary, abdominal cavity and broad ligaments, as seen on the current screen. Sometimes a pregnancy is not visualized on scan, and this is known as a pregnancy of unknown location. Shea et al. Defined interstitial pregnancy as an ectopic pregnancy located within the proximal intramural segment of the fallopian tube, transversing the myometrium. This type of rare abnormal implantation of pregnancy accounts for approximately 3% of all ectopic pregnancies. It can be difficult to distinguish between angular pregnancies and interstitial pregnancies, further emphasising the importance of correctly differentiating between these two. As a result of maternal morbidity and mortality vary greatly. The exact cause of interstitial ectopic is unknown, but it is thought to relate to an abnormal transport of the fertilized ovum within the fallopian tube. Risk factors include uterine abnormality, previous ectopic pregnancy, previous pelvic inflammatory disease, IVF, and the presence of an intrauterine device. Interstitial ectopic pregnancy is associated with a higher risk of shock and hemoperitoneum than other forms of ectopic pregnancy, as well as with a higher risk of maternal mortality due to the delayed diagnosis and high vascularity of the myometrium. Some signs and symptoms of ectopic pregnancy can be seen on the current screen. However, some women with ectopic pregnancies are asymptomatic and don't show any signs of ectopic pregnancy. The case study I'm going to discuss today is patient B. She is a 22-year-old female, gravida 2, para 0, surgical medical history, previous miscarriage of 6 weeks with expectant management. LMP was the 5th of Feb 23, making her 8 weeks pregnant. It was a planned pregnancy with a HCG of 8,271. The patient attended EPAU, referred by a GP, 8 weeks pregnant with vaginal bleeding and wiping, no abdominal pain. Due to the gestation age, it was determined that transvaginal scan was the most appropriate method to assess the location of pregnancy for patient B as per NICE guidelines. The initial scan report showed an anteverted uterus with an endometrial thickness of 14 mm, slightly thickened at the fundus but uniform in outline and texture throughout the uterine cavity. No convincing evidence of an intrauterine pregnancy or obvious retained products of conception identified on scan. Normal appearances to both ovaries between the right ovary and extreme aspects of the fundal endometrium is a 22 by 22 by 24 mm donut-shaped mass containing a single gestation sac, yolk sac and fetal pole with a CRL of 9 mm, which is 7 weeks. No fetal heart pulsations seen. It is difficult to determine whether this is separate to the uterine body, as imaging appears to be in continuation without separation or tubal. Left adnexa looks normal, no free fluid, confirmed ectopic pregnancy, location will need to be confirmed with further investigations. Patient was admitted for an urgent medical review. Guidelines and conduct, communication and consent. When performing an ultrasound, it is important that student sonographers adhere to their university and trust code of conduct. They must always follow guidelines and protocols set out by the British Medical Ultrasound Society, the Society of Radiographers, which includes safety, ethical, legal and professional issues, confidentiality, patient dignity and infection control. Upon meeting the patient, the sonographer must introduce himself to the patient and inform the patient of their role as a student and gain consent to scan under supervision. Ensure to do a full check of the patient's full name and date of birth before explaining the procedure to the patient. Gain valid consent and document it on the written report. Chaperone must be offered and the details should be documented on the scan report as per NICE guidelines. Effective communication is the ability to listen to patients, express interest, show compassion and empathy, provide knowledge and information to the patient. Communication is essential in all aspects of healthcare. The RCN, Royal College of Obstetricians and Gynecologists, and British Medical Ultrasound Society all highlight the importance of effective communication, emphasising this can have a positive influence on the efficiency of the appointment, the quality of the scan, and improve patient experience. Image comparison. When comparing the images of patient B to a normal intrauterine pregnancy, the major differences in ultrasound appearances can be seen. The first two images, images A and B, are that of a normal intrauterine pregnancy at the fundus in both planes. In comparison to patient B's images, images C and D, we can see an empty uterine cavity, a gestation sac, can be seen between the right ovary and the extreme aspect of the fundal endometrium. The patient was admitted for senior medical review, baseline observations obtained and blood sent. This included a serial beta-HCG. The patient became hemodynamically unstable after the scan and was taken to theatre. A laparoscopic procedure was attempted initially, however it was converted to a laparotomy procedure due to excessive bleeding from the site of the implantation site. Pregnancy was removed and sent to histology testing, which further confirmed products of conception. Patient recovered well post-operatively and was discharged home 2 days later with follow-up and repeat beta-HCG. The role of ultrasound. Diagnostic ultrasound has become widely used primary imaging modality in early pregnancy, owing to its lack of radiation, relatively inexpensive and easy accessibility. The ever-advancing ultrasound technology has resulted in wider utilisation of ultrasound to diagnose early pregnancy complications. A study carried out by McRae et al. 2008 reported that 80% of interstitial ectopic pregnancies were correctly diagnosed on 2D vaginal scanning. They further argued that there is no evidence that 3D ultrasound is more accurate for diagnosing interstitial ectopic pregnancies than 2D ultrasound. However, as with MRI scan, 3D ultrasound is not readily available, therefore not suitable for hemodynamically unstable patients. The Royal College of Obstetricians and Gynecologists 2015 argued that 3D ultrasound can take longer to perform and is subsequently associated with higher power outputs than that of 2D, which is not in accordance with the ALARA principle. According to Brincat et al. 2019, MRI scans can offer more detailed images for patients whose diagnosis remains uncertain, despite having a transvaginal scan. However, they are a lengthy and costly process and not suitable for patients that are unstable. In the case of patient B, she deteriorated soon after the scan, becoming hemodynamically unstable, therefore was not suitable for further imaging. MRI scans often need to use contrast agents, which are not recommended in early pregnancy. The Royal College of Obstetricians and Gynecologists and NICE Guidance both recommend the use of transvaginal scan and beta-HCG when making a diagnosis of an ectopic pregnancy. Management. There are several medical and surgical treatment options for an interstitial ectopic pregnancy. Treatment options depend on the gestational age at diagnosis, whether the pregnancy is ruptured or intact, and the patient's desire for future fertility. Minimal invasive surgery and non-surgical treatment options can be used for intact interstitial ectopic pregnancies. A ruptured ectopic pregnancy requires urgent surgical intervention with either a laparoscopic or laparotomy procedure. Surgical management includes hysterectomy, laparotomy, or a laparoscopic procedure, and medical management would include methotrexate. With the advancement of ultrasound enabling the early detection of abnormally implanted pregnancies and minimally invasive techniques, other management options now include direct injection of methotrexate into the abnormal pregnancy, combined systemic and direct injection technique, and laparoscopic corneal wedge resection. Grindler et al. Argued that there is no consensus on the best surgical procedure for interstitial ectopic pregnancy, and the best medical treatment regime for interstitial ectopic pregnancy remains unknown. Choice of treatment depends mostly on the clinical situation, stability of the patient's condition, and expertise. The diagnosis of interstitial ectopic pregnancy and management of ectopic pregnancy can be seen on the current screen. Differential diagnosis can also be seen on the current screen. The diagnosis and management of interstitial pregnancies remains challenging, in part due to the rarity of these cases and the lack of evidence due to guide management. The high sensitivity of ultrasound, when sufficient expertise is available, makes it the best first-line diagnosis for an interstitial ectopic pregnancy.